is, probably akin to the human growth and development type class that everybody takes in high school. And we're going to talk about the changes as we get older and we start out young. Tomorrow we get into the other side of this where we talk about geriatric medicine and what happens to your body as you get older. Anybody who's looking forward to becoming older, when we get finished with tomorrow's lecture, you will have changed your mind, I promise you, because the geriatric chapter spends, at least an hour talking about how everything just falls apart and goes to absolute hell in a handbasket once you're on the downslope. And boy, oh boy, can I attest to that. If I had known I was going to live this long, I would have taken better care of myself during the lifespan development. So here we go, chapter 7. It should go without saying, and I'm sure it probably does, that as we get older, things develop, things mature, and we're going to have some changes. When we talk in terms of pediatric medicine and pediatric patients, the one thing to always keep in your back pocket, and I think we've talked about it a lot when we talk things like shock and respiratory and cardiology, kids aren't just little adults, and we can't treat them that way. When we have a pediatric patient, we have a different set of guidelines and bits and pieces that we look for, and different ways that we're going to approach the patient, different ways we're going to speak to the patient. You can't talk to a pediatric patient in an emergency the same way you can talk to an adult, because everything's just going to go right over their head and you wind up missing. And kids, especially when we get to sort of the adolescent years and up into the teen years, they like to be involved in what's going on with them. They might not be able to put, all the pieces together, but, involving a kid in their care, letting them know what it is that you're doing, once they can sort of reason and make those types of bit of brain pieces fit together, is going to win us a whole bunch of credibility when it comes to treating a pediatric patient. There's all sorts of physical changes that the body goes under. There's developmental and emotional and changes in brain activity. And all of this is going to alter our approach to patient care. Arguably, the easiest ones to deal with are these ones. Neonates are birth to 1 month. We talked about them yesterday. Infant ages 1 year to 1 month. Why do I say this is the easiest age group to realistically deal with? What do you think?
Repeat that, I'm sorry.
Why would neonates and infants, when it comes to assessing and treating a child?
Because they're not at the age to fight you or try and interact, because they don't know anything, essentially.
Yes, they are physically dependent on an adult for everything. They are used to just being passed around to everyone under the sun because everyone wants to hold the baby. And realistically speaking, we don't have to chase them. We don't have to argue with them. We don't hear about all the things that they don't want us to do to them, and they don't want this and they don't want that. This is simple. Infants don't talk. They don't run away. They don't get scared of us because infants are used to being passed around to people. When we talk about their vital signs and things like that, generally speaking, we don't really take an actual blood pressure on our pediatric patients, especially this young. Really, anyone under the age of 3, we're not really taking a legitimate blood pressure on. Capillary refill will tell us a lot about our patient's perfusion status when they are a pediatric patient, especially of this age. When we assess a child, remember that childs are heart rate dependent, especially little itty bitty babies. The younger they are, the faster their pulse is going to be, the faster their respiratory rate is going to be, because they don't have a large blood volume. They don't have a whole lot of internal volume in their lungs for gas exchange to take place. So their little bodies do things faster as opposed to taking in or putting out more. Blood pressure does change as kids get on into age a little bit, it corresponds directly with weight and age and all of that. It will tend to go up as our pediatric patient, whether it's an infant neonate or, we move on into preschool and adolescent age, it tends to start to go up little by little until we reach preteen, early adulthood, and our vital signs all sort of level off to what they're supposed to be. But heart rate and respiratory rate is different. That starts high and begins to work down a little bit, because what happens as this baby begins to grow?
He's developing, he's changing.
They're developing, they're changing, their lungs are getting bigger, their heart is getting bigger and stronger, they're getting more blood so that it can accomplish, the work of being a larger person. So our heart rate and our respiratory rate as an infant progresses and works its way through adolescence and childhood and all that stuff starts to come down a little bit. And you'll see early adulthood where things level off to what we consider are actual within normal limits. Our heart rate of 60 to 100 and our 12 to 20 breaths per minute and our 120 over 80. All those stereotypical vital signs that we've mentioned so far. Kids, it's a crapshoot. They are going to have high heart rates. Their heart rate can be anything from 90 to 180 beats per minute. Their respiratory rate can be 20 to 30 or more and still be perfectly normal. It's all going to depend on how those things fit together and give us the picture of how is this child perfusing. If you have a heart rate way over 180, does that sound like it's reasonable, and does it sound like it's going to adequately pump blood around?
Flora?
Just as a general statement, when you think of the number 180, does that sound like way, way too many?
That sounds like way, way too many.
Yeah, so if we have even an infant or a neonate with a heart rate of 180, you're starting to put the pieces together now where you're looking for signs of poor perfusion. You're looking at a patient who quite possibly may need to be ventilated, because since cardiology and pulmonary systems are so closely interwoven, we're going to see both of those ratcheting their way up to try and keep up with the other one. And it's like, who's going to, it's like playing chicken. Who's gonna turn first? So yeah, sure, a high heart rate, 90, 100, 140, 150 in, an infant or a neonate, no problem at all. But if we start getting, 180, 200, 220, we're looking at something that is problematic. And the same goes for their respiratory rate. 30 to 60 breaths per minute for a baby at birth is fantastic. I would be so happy to see a baby that was breathing that fast. But as they get towards that 1 year mark, we're talking, they start to level off to 25 to 30, 40, even 50. But when you start looking at something and just say, arguably, reasonably, is that too fast? Is that too slow? Am I seeing signs that on top of being too fast, too slow, now I have some decreased capillary refill, and I'm starting to see a baby that's, not necessarily crying and a little more lethargic. We've started to now build our case for sick versus not sick. Our cardiovascular system changes the minute we start coming out. At birth, we switch from fetal to independent circulation. Fetal circulation means all of that oxygenated blood flow that we are getting through the placenta and the umbilical cord. When we switch to independent circulation, that means the heart is now working the way that it's supposed to, the respiratory system is now working the way that it's supposed to, and air is going in and out, blood is going round and round. It's the same function as with our adult patients. Rib cage is going to get bigger and expand some. We're going to increase that internal diameter, which decreases the amount of pressure in their chest, and gas goes in. Ventricles contract, and eject gas and eject blood out to either be oxygenated or deliver oxygen. And round and round and round it goes. This top bullet point here under the pulmonary system, why does it say infants younger than 6 are prone to nasal congestion? Why could that be a big deal?
Because they nose breathers, and that's all they do is use their nose.
Yeah, they are nose breathers. They are obligate nasal breathers. That means noses are for breathing and mouths are for eating, and the two never mix until after around the age of 6 months. So a nasal congestion like blocked sinuses and fully blocked nasopharynx could realistically be some form of airway obstruction for a pediatric neonate under the age of 6, neonate to infant. We already have talked at length about the differences in structure of our infants' airways. Proportionally speaking, tongue is a lot bigger. It takes up more space inside their oropharynx. The airways themselves are shorter and narrower, and they are way easier to physiologically occlude because they're not as rigid, they're not as structured, because none of that stuff has actually formed into hard developed tissues of cartilage. When we ventilate a child, so now we're talking ventilating our neonate or infant patient, we need to be very careful with the BVM to only give them enough on the BVM just to see that chest rise. How come?
We can actually blow out the lungs because they're so small. They need
Yeah.
the adequate.
Very, very fragile. We can cause what's called barotrauma to them by over or hyperinflating them. One of the other things you'll realize when you watch neonates or infants breathe is they're what's called belly breathers. It is perfectly normal to see their abdominal muscles moving when they breathe because their rib cage isn't as developed. The intercostal muscles aren't as strong. The actual mechanics of breathing are still sort of building themselves up. So we may see the actual abdominal muscles contract and pull down some. We have a bunch of different nervous system type reflexes that we can use to check things like neurological function, because it's not like we can ask them the conscious, alert, and oriented questions. It's not like we can ask them, you know, who's the president. The nervous system is developing as the patient is developing as well. When we do these reflex nervous system type things, that Moro reflex, that is when you startle a child, right? You know, you look at them go, boop. You see that their arms shoot out, their fingers spread open wide. They're like trying to like grab at the air. That's the Moro reflex. The Palmar reflex is, if you ever noticed, if you put your finger inside the palm of a little baby's hand, it squeezes it, it holds on, it grasps that object. The rooting reflex is if you touch their cheek, they instinctively turn towards your touch and will begin to try and suckle like they're trying to eat. The same thing goes for that sucking reflex. If you touch their lips, it's like they try to feed. These are all regular nervous system checks that we can do that actually do mean that things are sort of progressing the way that we want them to. Their neurological system is working okay. These fontanelles, also called soft spots, these are the bones that will eventually fuse together and make your skull have those immovable joints. We have fontanelles on the sphenoids, the mastoids, but the big ones we think of all the time are the ones in the top of their head. The posterior fontanelle right at the back, and then the anterior fontanelle sort of right in the middle of this pediatric patient's head. We look at these for some very specific reasons. These fontanelles will tell us how your patient's Jessica, you're all broken up.
Even difficulty breathing, those things go in and out if they really struggling to breathe.
So looking at these fontanelles, the posterior fontanelle usually fuses at around 3 months. The anterior fontanelle usually fuses itself together and creates a rigid structure in the skull between the ages of 9 and 18 months. These will tell us, is my patient dehydrated? These will tell us, is my patient having some sort of intracranial problem that's causing increased intracranial pressure just by looking at them. If we see a baby who's got this sunken in nature in that anterior fontanelle and they're crying but there's no tears, and the patient's caregiver says, oh, you know, it's been a few hours since I changed the diaper and I haven't been able to get them to eat anything all day long, does that sound clinically significant to you?
Yes.
How come?
Well, crying and no tears is already a red flag. But yeah, I don't know. Just it's not good.
It's definitely not good, but what's crying and no tears kind of
They're
tip you?
dehydrated.
Dehydration.
It's hydration. We've already seen the pictures that, you know, a baby that's only, 8, 10, 12 pounds only has somewhere around 12 ounces of blood floating around inside of them. 55% of that is the salty water that we call plasma. So if this baby loses a lot of fluid in a short amount of time, we already can start making the case for we're going to have hypoperfusion, we're going to have hypovolemic shock. It doesn't always have to be a hemorrhagic cause, but we look at the things we can look at and the things we can point our fingers right to and go, holy crap, this is not good. If we see great big giant bulging out fontanelles, that's going to tell me that there's some increased pressure inside that baby's skull. Could be from something like a fall, could be from almost just about anything, infection, illness. And you can look at that and say, boy, that's not the way that that's supposed to look. And then you start weighing that and measuring it against mental status and other changes you may or may not see. And it's going to real easy, real quick, real down and dirty, because that's how most of our pediatric assessment is done. Tell me a lot of things and tell me a lot of things that I really need to figure out in short order. Because what do we know about our pediatric patients? Since everything's so brand new and shiny, it works well for a long time, doesn't it?
Yes.
Until what?
Until it doesn't.
Yeah, until their little body decides that it's not putting up with it anymore, and then we are in the storm from that very given moment on. Looking at their immune system for the first few months, we've talked about this when we talked about anaphylactic shock. Under the age of 6 months, generally, these little kiddos are still protected by mom's immunity. So they are still reaping the benefits of everything that their parent had actually developed an immunity to. As they start getting older and start getting towards that 1 year mark, they begin to recognize more. They may begin to cut some teeth, the age of 6 months or so, it says. 8 months, they can start to understand things a little bit. They can sit up, they can play simple games. By 9 months, 10 months, 11 months, they are turning into a little person. They start to walk. They don't like being told what not to do. They may know their name and start using simple words. What is a neonate or infant child's primary means of communication?
Crying.
You got it. Crying. It is absolutely the way they get their point across. Bonding is based on time spent with someone and that someone meeting their needs. It could be a caregiver, could be grandma, could be grandpa, could be mom, dad, or anyone in between. Bonding is based on that secure attachment. They know when they recognize the face and the voice that this person is going to take care of what it is that I need. As they get older, some of that cause and effect sort of starts to show itself because they can have sort of a separation anxiety when they can't see that caregiver. Their sole basis on trust and mistrust is how they are provided for. Then we get to this group, toddlers. Boy, they're a lot of fun, aren't they? 1 to 3 years old. Pulse generally starts to slow down a little bit. We're talking 90 to 150 beats per minute. Respiratory rate starts to come down a little bit. As we get into the older toddler phases, we will start checking blood pressures a little bit more closely. We don't always just rely on capillary refill. We're looking for something between 80 and 100. You know, think about that. If you had an adult patient whose blood pressure was somewhere around 80 systolic, you would already know that we're having a bad day. But at 3 years old, blood pressure of 80, 90, 100, somewhere in there, perfectly fine. As we get into the older toddlers and preschoolers, 3 to 6 years old, you can see the pulse starting to come down even more. You can see the respiratory rate starting to come down even more. Their systolic blood pressure maintains right around the same. One of the things to think of with toddlers and preschoolers is they are very literal creatures. So something that we say all the time, I'm going to take your blood pressure or take your pulse. What does someone in this age group think immediately?
You're stealing something from them.
Yeah, you're taking something away from them and they probably think it's going to hurt. So choose your words very, very carefully with this group. Kids in this age group don't have the same understanding that as we get older we do. But one of the things that you need to remember with kids, especially toddler, preschool age, is their memory is unbelievably long. Realistically speaking, try to tell them the truth. If they ask you if something is going to hurt and you tell them that it is not going to hurt, and it does, you are burnt forever. They'll see you at the grocery store months down the road and remember you as the person who said it wasn't going to hurt. So do what you can to sort of leave anything like maybe a finger stick or things of that nature that are going to be painful until towards the end of your assessment, because they are likely to be very, very unhappy with you. Their lung tissue and the musculature of the mechanics of breathing are still developing. They're not as big and rugged as ours are. So they can't really breathe very rapid, very deep for a long period of time. This is part of the reason that they are, you know, prone to maintaining, compensate, stop. Because once they have reached the limit of what their lungs will do and what their body will do, they don't have any reserve left. You know, it's one of those things that it has a time frame. Now, not time as in how many minutes is this going to go on for, because you never really know. But since we understand that these things are still developing and still coming into their own, we need to be sort of on about the job of figuring out just how sick are we. And when we get into our pediatric lecture, we're going to talk about the pediatric assessment triangle, which gives a really good sort of bird's eye view into how we figure out how sick is this kid. Between this age group, they lose that passive immunity. That immunity that they got from mom is no longer a thing. This is why a lot of the times, this is when kids will get most of their immunizations and booster type shots, because that passive immunity has gone away. They start growing and developing neurologically and muscularly over this time period. They say the average age for completion of toilet training is about a little under 2.5 years old. They learn to speak and express themselves. They are speaking and mastering the basic language that's spoken around them. They're going to be social creatures. They interact and play with other children. These kids of this age group understand cause and effect. and they are constantly trying to do things that are deemed good versus bad, right? These kids don't like being in trouble. And sometimes when they're in an emergency situation and they're really sick or really injured, they look at it as like a punishment. So we have to be like armchair psychiatrists when we're talking and dealing with little kids. The more trust you can earn with this age group, and as we get on a little bit more, and the more time you spend with them, the more likely you are to have a positive interaction with them. So as far as our pediatric calls go, unless this kid is so sick, you're like, holy crap, we're going to be working a cardiac arrest here soon. So critically ill, critically injured. Take a little time with them. Let them play with your toys, play with their toys, show them the stethoscope. Do whatever it takes to win this age group over. And you're going to have a much easier time at getting your assessment done. You're going to have a much easier time at figuring out what you can do to best support them. But even at this age group, they're starting to learn the language. They're figuring things out a little bit. They speak, they express themselves. They pull no punches about telling you what they don't want you to do. But are they going to be able to explain things to you about what's going on with them and what's wrong with them for the most part? What do you think? Do you think we're getting a lot of good information from a verbal assessment with this patient?
Probably not. Just gonna say that
No.
everything hurts.
Yeah, we're not going to get much. We're not going to hear anything about what their history is because they haven't been around long enough to know it. We're not going to hear anything really, really tangible. Involve the caregivers. Let the caregivers tell you everything that they know about what's going on, because they're going to be able to tell you what is different. People call 911 because something is different. Something has changed. And if you can get to the bottom of that and let the person who's responsible for the general day-to-day well-being of this pediatric patient tell you what it is that they feel is different, it starts to turn the wheels a little bit for you and figure out, all right, well, they're saying that their kid's been sick for a couple days now, pretty lethargic, been nonstop eating, nonstop drinking, nonstop peeing, had 2 accidents yesterday. And then you start thinking, all right, lethargy, polyphagia, polydipsia, polyuria. Holy crap, this kid's diabetic. And you take a finger stick and their blood sugar is 680. And you've just figured it out. And it took all of a minute into the actual assessment of this child. And you didn't even speak for real to the kid. Your partner's on the floor playing blocks or GI Joes or just dealing with a lethargic little kid trying to keep them awake and support airway breathing and circulation. And we've answered the question. Moving on into our school-age children, 6 to 12 years old, vital signs begin to level off and turn into, again, what we consider our normal, right? 70 to 120, that's not outrageous. Respirations of 15 to 20, that's still looking good. Blood pressure still starting to creep up there, 80 to 110. The smaller a kid is, the lower that number is going to be. But as we start getting up to 10, 12 years old, we're going to start seeing that systolic blood pressure getting up around 100, 110. Through this age group, we're going to start to see changes in body appearance and body function. As we get to the outer reaches of our school-age children and 12 years or so years old, we start to look for things that denote to us the arrival of puberty. So initial stages of breast development in a female, underarm or body hair in a male patient. They will start to lose their baby teeth and permanent teeth comes in. They start to have more brain activity on both sides. So now both hemispheres are a little bit more active. There's a bit more next level thinking as this patient gets a little bit older. They still have that reasoning of trying to act to avoid punishment and wiggle it towards getting what they want. This is where they start to really develop their personality. They're looking for approval. Everybody wants to be liked. Everybody wants to be the popular kid at this age group. They start to actually develop their conscience and have a concept of self. Their self-esteem becomes very, very important to this age group. So thinking of things like patient assessment and having to cut clothes on a pediatric patient that is 12 years old. Chase off anybody that doesn't need to be there. Anybody that doesn't belong and isn't part of the assessment, take a powder, get out of here. Because kids don't want to be viewed in this realm. They don't want to look like they're sad or upset or crying. So anybody that doesn't have to be part, hit the bricks. Moving on now, we're into our adolescent years, 12 to 18 years old. Our vital signs are finally approaching that of an actual adult. So this is where we start to see things actually finish doing their growth and development. This is sort of the end of our lifespan development. Everything starts to get to its normal sort of homeostasis spot and turns into an adult person. Generally speaking, girls finish growing around the age of 16. Boys will finish around the age of 18. They have what's called growth spurts, where they have those just huge increases in height and body weight and structure. They have finishing development of their reproductive organs. Their voices will start to change. Menstruation typically begins around this age group in females. It can begin even earlier. It says here that adolescents and their teenagers and their families often deal with conflict. Anybody remember back to being a teenager, or anybody out there have a teenager possibly? And I'm sure I'm not telling you anything new. Privacy becomes an issue. All they want to do is be left alone and have a little bit of space to themselves. Self-consciousness increases tenfold, and they're always constantly worried about what everybody thinks of them. And it's a bit of an identity crisis. They have a difficult time finding their little niche, finding their little space in the world. Jessica's got a 13-year-old.
Yeah, my sister's 13 and she hates everyone.
Yeah, that's kind of the breaks. It gets better. I got one that's 21 and our youngest is 16. So they run the gamut. It gets better. One of the things that we think of with teenagers is that little bit of rebellious streak. You know, they start to develop that antisocial behavior, peer pressure, and what their friends think of them become, paramount and the biggest things in their world. They start experimenting with things like smoking and drug use and possibly alcohol, unprotected sex. This is when we see things like eating disorders possibly beginning to develop, but they do develop that code of ethics. They get to some of that development of their right versus wrong. And a lot of this is nature versus nurture. You can watch the news and turn on the TV, and you can see all sorts of crazy things happening all over the place. But this code of ethics generally develops at home. What you see at home as right or wrong is generally who you develop into as a person, and that's your acceptance of what is right versus what is wrong. Kids in this age group, because of all the stressors, because of all the changes, because of all the hormones, are at a huge, huge high risk for things like suicide and depression. And it is really something that if they would just give it some time, we go from this adolescent type, you think the weight of the world is on your shoulders and everything stinks and the whole world's crashing down around you, to get to be somewhere between 19 and 40 years of age and realize, holy crap, the whole world stinks and everything's crashing down around me, but my little spot in it's pretty damn good.
Amen, Tommy.
You learn to take things with a grain of salt as you start to approach some of these, like the next slide when we get into middle adults is where I'm headed. And You know, I used to think people that were 40 were old. So 19 to 25 years old, your body's functioning at its optimal level. This is a finely tuned machine that we're talking about, 19 to 25 years old. Life typically centers around responsibilities, work, family, other things that are stressors like finances. You start to get to the point as you're settling down and having kids and starting all of this all over. And this is realistically one of the more stable periods of life. This is where you've gotten to the point where this is the path that I'm on and this is the path that I'm walking. Not much change in vital signs, not much change in the way your body functions or the things that it does till we start getting here. Middle age. Vital signs aren't going to change a whole lot. Your ability to see and hear begins to decrease. This is where cancer is at its highest incidence. Menopause can start as early as 40 years old in females. You start having problems with diabetes and high blood pressure and controlling your weight. You know, things that you could eat when you were 19, 20, 21 years old, you look at between the ages of 41 and 60 and put on 10 pounds. So it's just, you start to have some metabolic changes. You start to have a whole lot of things beginning to happen. And keeping good care of yourself in the early stages of this middle adult period is definitely where you're going to earn your most bang for your buck, because if you throw caution to the wind at this age, the 80s, 90s, and 100s are not going to be kind to you. Our psychosocial in middle adulthood is just really focusing on setting and achieving goals. This, as we get older and further and deeper into that, we start to think about, you know, people who are beginning to downsize and preparing for their kids to leave home. And they generally have a pretty good view of the world at this point and are really able to handle the things that life throws at you between, you know, the later part of your early to your middle adulthood. And you have things that are pulling you in opposite directions, which makes the fact that you do have the emotional reserves to put up with that sort of best case scenario, because your kids are getting older and leaving for college and starting on their own life and maybe having their own kids. So you have obligations there. You have parents that are quite likely still to be alive and getting older. So you have responsibilities pulling you in that direction, and you have a lot of stuff to take care of. So all this growth and development you've done to this point is going to be well spent here. And then we become older adults. They term this as 61 plus. The life expectancy as of the publication of this was 78 years old. It's probably even further along than that now, with healthcare being what it is and the ability to sort of maintain chronic diseases. People are living longer and longer and longer all the time. Vital signs in this age bracket are going to depend on how healthy they are, and like I said earlier, how well they took care of themselves in their misguided youth. They're going to depend on what they have for medical conditions, what they have for medications. Do they take them the way that they're supposed to? As you age, and remember this for tomorrow's lecture, as you age, all of the things that were fresh and shiny and new off the factory floor when we started talking about neonates are getting towards the end of their warranty. Things are beginning to wear out, things are beginning to break down, and things are beginning to need some sort of management from a medical standpoint. So they could have multiple medical problems, they could be on a laundry list of medications, and it could be all just for the management of these older years. That atherosclerosis, that product of aging, we have those arteries in our hearts becoming less elastic and less able to expand and contract. We have a decrease in our cardiac output. We have stiffness developing everywhere. The ability to replace the blood cells that are constantly dying off and being replaced begins to decline. So we'll see things like anemia or respiratory issues, or even a person who doesn't have what we would look at in a younger person and be like, holy smokes, that's a significant bleed, can be problematic the older you get. Even little insults, the body has a difficult time maintaining itself sometimes. Our respiratory system, we wind up with those same changes. The airway actually gets bigger, but the surface area of our alveoli starts to break down and get smaller. So we have less space for that gas exchange to take place. The lungs are less elastic and less able to do their job. It actually becomes a little bit more work to breathe. We have muscular breakdown, which can lead to possible aspiration of things like food and liquids. The residual volume in our lungs, so that leftover dead space actually gets bigger. The amount of vital capacity, so the amount of space that is available for that gas exchange, gets smaller. All of these things, every little thing becomes that much a little bit more difficult. Our endocrine system changes. Our pancreas won't produce as much insulin. Our body won't use it quite as well. Metabolism decreases. Physical activity decreases because of changes in the musculoskeletal system. So they don't need to intake as much food as they used to. They don't break it down as fast. They constantly feel full and like they don't want to eat. Hormone production goes down. We may have decrease in typical animalistic desires, like things of a sexual nature. And it's just because of all the changes that go on inside of our patient. Now add to the fact that your metabolism slows down, so you constantly feel full. Your taste changes. Your saliva secretion decreases, and you actually have a decreased ability to move this waste product through your GI system. And you can understand now why Nana never wants to have anything to eat. And when you force her to sit down and have a meal, she eats like a hummingbird and is full just a few minutes later. They lose that joy of nourishing themselves as you get older. It's not as satisfactory as it once was when you were younger. Our kidneys, well, same here. Filtration actually goes down. Kidney size goes down. You have a decreased ability to clear wastes from your body. You have decreased ability to conserve fluid. So your kidney's job is to maintain a balance. And if we get to a point where we are dehydrated, our kidneys will actually secrete some hormones that make us retain water. Older adults don't generally have that anymore. They have a decreased ability to do that, so they're more susceptible to things like dehydration. Our motor and sensory networks all begin to slow down. Neurons in our brain are actually lost. Sleep patterns will change. Have you ever wondered why, an elderly person will go to bed at 6:30 in the evening and wake up at 3 o'clock in the morning like it's the normal thing to do? It's because their circadian rhythm changes. They begin to sort of lose that normal, I have to get up at this time and go to work, and I have to go to bed at this time so that I can sleep through the night. And the last little bit we have here is psychosocial changes. This is a good one for me. Most people retain high brain function until around 5 years before their death. So that means, even right up into next door to when it's getting close to time to pass away, people are still able to maintain their brain function. They're still able to maintain themselves as a normally functioning human. 95% of our elderly people live at home, but living at home comes with its own bit of financial cap and financial problems that limit their ability to maybe afford their medications or afford appropriate food or afford the ability to heat their home. Isolation and depression become a real thing. They start to see that their friends are passing away. Maybe they've lost a spouse. Maybe they've actually buried a child. So you start to look at some of the factors that will push an elderly person towards depression. Believe it or not, this is another age group that suicide and suicidal attempts and plans are of huge, huge concern, because they've quote lived a good life. They've lost all their friends, they've lost all their family, they've lost all their ability, they've lost maybe the ability to live on their own. Maybe they've, you start to see the things that are chipped away and taken away from them as they get, 60, 70, 80, 90, 100 years old. And some of them decide not to do it anymore. All right, that was lifespan development. Does anyone have any questions in the realm of how the body changes as we get older?
Nope, I think we got it.
Yeah, I feel like that one's pretty straightforward. So next we have pediatrics, but we're going to take a break first. We just need to get the right page up here. All right, let me see what time it is. I have about 9:30. Let's take around 15 minutes. We'll come back and we'll get on to the pediatric lecture. So we already went over the lifespan development bits and pieces of all this and talked about the changes that come along. And this introduction really should, at this point, since we just talked about all this, go without saying. But anatomically, physically, emotionally, kids are different than adults. Their response to that adult is going to vary based on their age and how far along they are in this whole growth and development portion of life. This middle point, I can't stress enough. Children are not small adults. We need to approach kids much differently. We need to have a much lower threshold for deciding sick versus not sick when it comes to kids, because the time it takes for a child to finally look sick, they are really sick. And you have to keep that in mind. I mentioned the pediatric assessment triangle in the first lecture this morning, and we're going to go over that in great detail. I actually am going to bring up a separate slide at the end of this presentation so we can actually look at the pediatric assessment triangle, which is sort of our general impression of a pediatric patient. And when we look at it, it tells us, is this a respiratory? Is this shock? Is this what is going on? And you can pick those things out in front of you and you can actually look at your pediatric patient in seconds and decide respiratory distress versus respiratory failure, respiratory distress and cardiac compromise showing signs of poor perfusion, so shock. You can look and figure out compensated versus decompensated. You can realistically put your finger on the pulse of what is going bad in no time flat. Everybody gets nervous when we talk about pediatrics and going out on kid calls because, well, kids are little. Generally speaking, they didn't do anything to put themselves in the situation that they're in. The situation just came and found them. One of the things that I hope gives you a little solace in this point is pediatric calls are a very small percentage of our general call volume. On top of that, actually critically very ill children are realistically just under 1% of the total emergency medical service system call volume, period. So 1 out of every 100 or less will you ever happen to stumble yourself upon a very, very sick kid. When we wind up caring for a pediatric patient, one of the things that we always have to keep in mind is we are also caring for the caregiver. The people that take care of this child every day generally need a lot of support from us. A calm child is the product of a calm parent. So when mom, dad, caregiver, grandma, grandpa, whoever is all worked up, we need to get them to focus their energy on remaining calm and instilling a bit of peace and tranquility over this wild and crazy scene that's in front of us. Because having our patient further amped up by the fact that they're the person they look to for how they're supposed to respond to things being all amped up is just going to serve to make them sicker. As a provider, this is one of those be the duck type situations. If you've ever seen a duck floating along on a pond, it looks like just effortlessly, it's sitting there on top of the water, floating along, minding its own business, like nothing going on. If you've ever seen video of what a duck has to do to float like that on top of the water, its feet are going a million miles an hour and it's kicking like all get out in order to stay just that nice, serene look on the top. Outwardly, calm, efficient, professional. Inwardly, you could be freaking right the hell out because you have a sick kid in front of you, but that can't be what you give off. You have to just maintain that sense of decorum and just deal with the problems as they present themselves. I'm skipping over a few things because the beginning of this is growth and development. So, the assessment-based approach to our pediatric patient. First and foremost, like I said, be the duck. When you know you're getting dispatched out on a pediatric call, mentally get yourself ready for that. And that's not just, all right, this is a pediatric patient. We start thinking mechanism of injury, nature of illness, what could be wrong, blah, 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 blah. No, mentally prepare yourself for the fact that there is going to likely be a sick pediatric patient right in front of you. Make sure that you pack up all the appropriate equipment. Make sure that you are ready to do an age-appropriate physical assessment. What do you think an age-appropriate physical assessment means?
If it's a baby, if it's a toddler, certain things you're going to need for them.
Yep. And really, how you approach is going to be sort of a big thing. Your pediatric patient, especially the younger pediatric patients, so infants, neonates, we want to start from the toes. We don't start right up in their face because that adds to the sort of stressful nature of what's going on. We're going to allow the parents to be a part of all this because being with their caregiver, being with the person who is responsible for their well-being, generally should add a bit of calming sense to the environment. Parents generally are pretty good at calming their child when placed in a stressful situation. Removing that parent or removing that child is really not going to do you anything as far as how you're going to be able to manage this patient. It's likely to just make the situation worse. We start getting into our scene size up. Remark of certain things, right? How was the patient found? Where was the patient found? They could, I suppose they could have an infectious disease. That's not quite as likely, but kids do wind up with all sorts of viral and bacterial infections, and make sure your proper PPE is in order. Assess the environment around you. Start trying to figure out, is it possible they ingested something? You start working through, and this is just the scene size up. We're starting to try and put the pieces together as we approach. Take a look at what's up there right now and tell me why some of that is an important thing to think about. traumatic scenes or trauma or an unresponsive or too young to communicate, why are we going to assume right off the bat that this was the product of something significant to injure their head or neck? Because we don't make those same assumptions with adults all the time, do we?
No, because they're little. So anything traumatic, a hard fall, they can break their necks easily. Or
Yeah, they
even
got
just
that.
playing. Even playing, they can hurt themselves.
Yeah, they got that great big giant head and really no significant muscular structure holding it up. Kids are, as far as surface area goes, their heads are huge compared to the rest of them. Another point where we have a very low threshold for what is going on here. How sick is this patient? Do I need to take these extra precautions to make sure that I'm not taking something that was just a small injury and making it a catastrophic injury? So if they are unresponsive, especially the younger they are, because they do have those soft spots and their skull is not completely fused together and rigid and hard like ours, start thinking head and neck injuries and cervical spine immobilization when you start thinking of an unresponsive or unable to communicate or possible severe mechanism of injury. And now we're into our primary assessment. So here it is. Take a look at this triangle and tell me what it is that we're actually looking at. Now it says right there, sick or not sick, but what is this telling me?
Appearance, color, breathing, and skin. Circulation to the skin.
Okay. What do those three things add up to?
Our primary assessment.
Our primary assessment and our patient's perfusion status.
Yeah.
Just by looking, not even touching. We are doing this from the doorway. The minute we lay eyes, I want to look, is this pediatric patient responding appropriately to the environment? Kids that are sick and look lethargic or listless or are, not really responding to the environment. Well, I know my appearance stinks, so it's quite likely that either this or this is either already a problem or going to become a problem. This pediatric assessment triangle is going to be what kicks off all of the rest of your patient assessment. It is what really lights the fuse for how sick is this patient and how quickly do we need to be moving towards an exit. Because let's say we have increased work of breathing. We have a kid that's grunting away and making all sorts of noises when they breathe. And they have poor skin color temperature condition. And maybe their appearance is still okay. Maybe they're still, responding to the environment. But after a couple minutes being there, you start to see that head bobbing as they're breathing. And their work of breathing went up. And this went down. And now their mental status, so their level of consciousness, is starting to fail. We have now reached decompensation for sure, without ever even laying hands still. We have evaluated somebody who's in decompensated shock. We have reached the point of near cardiopulmonary collapse because their little body has maintained for so long and just clicked away trying to keep itself alive that it's getting to the point where it's going to quit doing that. And this is quick, fast, and in a hurry. It requires no equipment. It really requires you to do no touching, so it's non-invasive. A lot of this is visual. You really get to just look and make a determination. Because by the time we see this triangle starting to fall apart, it is without a shadow of a doubt a sick patient right there in front of you. If we find any problems, we treat them. This is primary assessment 101. If you have a problem in this general assessment and beginning to obtain your primary assessment. If we do have an airway, breathing, or circulation problem, that problem gets fixed. If we didn't find a problem with our pediatric assessment triangle, this is likely a patient that, at least for the time being, we can spend a little bit of time with, and we can, really get to the real finer points of assessing a pediatric patient. If we have a stable patient, right, we're not going to be in a screaming hurry. We're going to be taking our time, playing blocks on the floor, letting the kid take our blood pressure as opposed to taking theirs, or checking their blood pressure so that they don't think we're taking something from them. Some of the best pediatric assessment I ever did, I spent 5 minutes on the floor playing with a kid, G.I. Joes. And I got to learn so much stuff about talking to a pediatric patient. Why? Because he wasn't super sick. If he had been super sick, I would have scooped him up and we would have been on our merry way to the emergency room so fast, his ears still would have been hanging in the air when I left the house. But if you have time, take time. Rushing with a kid is generally not going to win us any awards. When we get into the hands-on assessment, we're looking to the airway as usual. We need to remain open, clear, and secure. We have to have a patent airway. If the patient is unresponsive or can't maintain their own, we fix it. If it's mucus, vomit, blood, or any gurgling noises, we suction. If it's a foreign body obstruction and they're unresponsive, how do we clear an unresponsive pediatric airway with a foreign body obstruction? NPA might be something that goes in. Finger sweep if what, Jessica?
If obstructed, if we can see or feel something in the neck.
Yeah, so we go ahead and pluck that obstruction out if we can see it and safely remove it. But let's say it's way down deep on top of their epiglottis. We can't see it, we can't get it. How are we going to get that foreign body airway obstruction out? They're choking.
Slap them in the back. And chest
That's if
pass.
they're responsive. What if they're unresponsive?
CPR. Chest,
Bingo.
the chest.
Massage the chest.
We're going to do CPR beginning with compressions, and every time we go to ventilate that person with the foreign body airway obstruction, we look in the airway and see if we find the obstruction. If we do, we get rid of it. If we don't, we keep going. Kids, when we talk about positioning their airway, so we're still talking unresponsive. Absolutely, you can do NPA, OPA for sure, but our pediatric patient, since they do have that great big whopping head, we want to put them in the neutral sniffing position. It should look like they're smelling cookies. And we do that by putting something between their shoulder blades to lift their shoulders up and their chest up anterior so that their head has room to go back and their airway maintains itself nice and open. Either way, whatever it takes to maintain that airway is what we do. After we've done that, we move on to breathing. We're still going to look, listen, and feel. We're still going to do all the inspect, palpate, auscultate their lung sounds. We should still see chest rise and fall. We may absolutely see belly breathing in an infant or a small child because the structure and musculature of their chest has not developed quite yet. If we see bradypnea, what does that mean?
Is
Slow
that
breathe.
Yeah, slow breathing. That not only could be an ominous sign, that is an ominous sign. Bradypnea and bradycardia are like ticking time bombs when it comes to our pediatric patient. That is a pediatric patient who has been sick and who has been maintaining and who has been compensating for a long time, and they are getting ready to quit doing that. So be very, very suspicious if a kid is breathing really slow or has a very slow heart rate. The same circulatory checks apply. Rate, rhythm, and quality of their pulse. We're still looking for bleeding or something that can cause them to be going into shock. Infant pulses, we check brachial or femoral pulses. Remember, we don't check carotids on them. If they're over the age of 1, we can start checking a carotid pulse. Generally speaking, if we find strong central pulses, so our femorals are good, our brachials are good, or our carotid over the age of 1 is nice and strong and full when we put our fingers on it, that means the child is generally not hypotensive. If you add to that good peripheral pulses or fast capillary refill, our perfusion status is probably pretty good. But if we find problems with our pulse locations or increased amount of time for their capillary refill, then we're starting to now chip away at their perfusion. We're starting to develop the thought that maybe we have some problems here. Our primary assessment is going to get us very, very far with assessing a pediatric patient. Tachycardia is absolutely one of the first signs of hypoxia in a child. Kids are very much rate dependent when we talk about respiratory and cardiology. And it is likely that their heart rate and their respiratory rate will go up in order to try and maintain and compensate. Put all of this together and get our pediatric assessment triangle all buttoned up with a good, solid primary assessment, and it's going to put us in the right neighborhood, at least, to figure out how ill this patient is. Because the actual pediatrics portion of this, like the actual medicine of pediatrics, damn it, it's hard, because kids can't tell us things. Kids can't, they don't have the ability to be as involved in their care as an adult typically does. But if we can maintain these things and realize these problems really, really quickly, we at least give downstream and the advanced providers and the people that are responsible for actually correcting these problems the best chance at having a viable, successful story with that. Skin color, temperature, condition, capillary refill time, all of these things go together to tell me, how is this patient perfusing? Much like with everything else, our approach to getting a history from a pediatric patient is age dependent. We're going to get all of our information, all of our verbal portion of our assessment from whoever the caregiver on duty is. They're the ones who's going to give us our information for, infants, toddlers, preschool age. They're not going to have much to tell us. As the patient gets older, the information gets better. So adolescents, teenagers, young adults is going to be more involved. They're going to be able to tell us more. We still will talk to the parents. We will still ask them questions about what caused everyone to call 911. As far as, how we start picking away at these things, well, much like with anybody else, it's the chief complaint. We look into the patient's chief complaint, or we look at the mechanism of injury, and that gives us all of our baseline information that we're going to get. And then we ask our questions from there. We tailor our response based on what the patient's chief complaint is. We start looking at nature of illness, mechanism of injury. Why is it important to figure out how long a kid's been sick for?
So we know how long their poor body's been struggling.
Perfect. What about things leading up to the illness? Why is that got any sort of significance?
Because that we'll know what made them sick.
We could know what made them sick, or we could know, it'll help us sort of trend their signs and symptoms a little bit. They say, oh yeah, they were sick for a couple days, didn't feel well on Thursday last week, and then by Sunday really was complaining, and then Monday, still kind of sick and, spent most of the day in bed, and we went to wake them up this morning and now couldn't. You think about the onset of that problem. You think about how long that issue has been going on for as far as the time. And you go, holy smokes, because they have likely been sick since Wednesday, Thursday, a week ago. But since kids are generally healthy, that's not unheard of. And it's not even anything that, could have been done different or could have been done better because, oh, they just got some viral thing. I mean, how many times anybody out there with kids has heard, oh, it's just some sort of viral infection, it'll run its course. All the
Oh,
time,
I hate that.
right? And it
Yeah,
is
and then a week later you wind up in emergency room or they can't breathe or some shit.
right. And I mean, sometimes it's legitimate, and other times it's just, you know, an ounce of prevention over a pound of cure, I guess. I don't really know. But any changes to these things or any real significant changes, because kids are creatures of habit. So anything that changes along the way here as we're asking these questions is likely to be somewhat of a big deal. When we ask our sample and OPQ-RST questions, thankfully, none of these things change, except really who we're going to ask them to or how we might approach them. Even in, adolescents and younger adults, they do have a tendency to regress when ill or injured. So they may act like a younger child than they are. Keep that in mind. And also their vital signs when they are exposed to things that will cause their body to need to compensate. We now see vital signs going up. So it is likely that we will have very fast heart rates, very fast respiratory rates. And we just need to know the physiological internal differences with these patients. Staying in the same bit, well, our physical exam doesn't change. It's going to be the entire body when our patient's unresponsive, doesn't matter. If we think they have a significant mechanism of injury, it's going to be the entire body. We're still going to use DCAP BTLS. Somebody out there tell me what DCAP BTLS means.
Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling.
Good. If our patient doesn't have any life threats or doesn't have any significant mechanism of injury, again, much like with our adult patient, we're going to focus on the chief complaint. We're going to focus on the mechanism of injury and evaluate that, non-multi-system trauma patient or medical patient accordingly. Like I said, infants, toddlers, preschool age, they're going to clam up if we start working from the head down. Generally with this age group, especially as long as it's not a primary assessment problem, so something with airway, breathing, or circulation, we start at the feet and work up. As they get older and school-aged and adolescents, we can click right back into our normal adult assessment and work head to toe. But if your pediatric patient in the younger age categories is having an issue, generally you're better served to work from the toes and work your way up. A good guesstimate of what a patient's blood pressure should be over age, if they are under 10 years of age, 70 plus 2 times their age is going to give you what their systolic blood pressure should be. So if your patient's 5, their blood pressure should be around 80. Your patient is 10, their blood pressure should be somewhere in the neighborhood of 90. That makes sense to everybody?
Yeah.
No, maybe. All right. All right, now we're going to talk a little bit about some of our common problems. Asthma is a humongous issue with our pediatric patients. Luckily for us, it's the exact same mechanism, it's the exact same problem, it's the exact same treatment. The bronchioles become inflamed, they swell, they increase mucus production, we'll have difficulty breathing. There'll be a tightness. What's the lung sound that we expect to hear on our asthma patients?
Wheezing.
Hoarse, wheezing.
Yep, wheezing. On the in or on the out?
On the out.
On the out, yep. Audible expiratory wheezes is a good indicator for our asthma patient. This can be a true deadly emergency if it's not caught and fixed. We've got our signs and symptoms. Somebody out there, please tell me what the treatment is.
2.5 milliliters nebulizer.
Is it 2.5?
Or 0.5.
I think it's 2.5 to 6 for kids.
Yeah, so it's double the amount of saline because we want a total concentration of 1.25. So
1.5.
yeah, we put more saline in because we needed to dilute the medicine. 2.5 is your adult dose, and then we want 1.25 for a child in the nebulizer.
So that'll mean one of the premix and extra saline.
Yep. Very nicely done. And I think that's probably where you came up with the 6, but 1.25 is the number we're looking to end with. Some albuterol actually comes packaged as a pediatric dose, and it's already got the 1.25. So it really just depends on what you're carrying. So knowing your equipment. Good, good, good.
So I would have been right if it was an adult, 2.5, right?
Yep.
Okay.
So moving right along, now we have gotten to croup, another respiratory type emergency. This is generally speaking, a viral infection in and around the patient's vocal cords. Generally, this happens in the fall-ish. It's between the ages of 6 months and 3 years old. Kids will pass this back and forth to one another like nobody's business. And the hallmark sign of this is either stridor or a seal-like barking type cough. Treatment for this is generally on our level humidified oxygen. Sometimes cool air helps. Sometimes warm air helps. A lot of times parents will know, oh yeah, well we generally bring the kiddo into the bathroom, turn the shower on, and let that nice warm humid air clear this up. And a lot of times we'll get the phone call when that doesn't work, and this persistent seal-like bark and some stridor starts showing up. And our treatment is going to be respiratory in nature. We're going to go ahead and give that humidified oxygen. Some of the chief complaint to go along with this is generally it starts with a cold and a cough and a couple days of like low-grade fever. Kids have the ability to spike these just crazy, stupid, outrageous fevers and be just fine. Whereas an adult, we would be cooked to done. Kids can have super, super high fevers. Kids generally get really sick when their fever goes from normal to really high in the blink of an eye. So it goes from, 98.6 to 102.4 in 10 minutes. They'll have what's called a febrile seizure. But if a kid just slowly creeps up to a temperature of 102, 103, they typically tend to do okay. Doesn't mean they're not sick, but it doesn't mean that they're going to seize right there in front of you either. It's going to generally stimulate a febrile seizure when a kid's temperature spikes fast. Next on our list here is epiglottitis. Epiglottitis is around the same area as our croup patient. But what happens here is this is a bacterial infection. This is way worse. The bacterial infection creates so much swelling that the epiglottis is like 2 to 3 times the size that it's supposed to be and can completely occlude the airway, cause a crazy, ridiculous sore throat to the point where this patient sits forward with their chin jutted out like a bulldog and just drools continuously because it hurts too much to swallow and they're too afraid to swallow because it feels like their throat is going to close because their throat is going to close. Epiglottitis has gone down in incidence, which means it doesn't happen as often as it used to because they have developed a vaccine. If you have a patient that presents to you this way, they look sick, they have a sore throat, they have a really high fever, they're sitting in that position, what do you think your care for this patient is?
High flow oxygen and transport.
All right. Let me ask you another follow-up question. Does this sound like a patent airway?
No.
No, this is like about as scary as an airway gets. So this is for sure not a patent airway. What that means is we want to be very, very gentle in the management of this patient. We don't want to do anything to aggravate their condition because this airway is well on its way to closing all by itself. And anything that will stimulate that to happen faster is bad news. So nice and calm, very easy. If tolerated, oxygen. If not tolerated, leave them alone. Nothing by mouth. Don't do any type of inspection or palpation. If the patient presents to you in that fashion, get on about transporting and get them somewhere in a much more controlled environment where if something goes poorly, at least it goes poorly with like anesthesiologists and things of that nature, because that is an airway that is just waiting to be triggered to close. Whooping cough is another one. Whooping cough has a bit of a telltale sign to it as well. At the end of their coughing fit, which generally this triggers a pretty ridiculous coughing fit, they are really make like a whooping noise. Like they get through that coughing fit and the end of the coughing fit is ooh, ooh, because their epiglottis is closing, their larynx is all swollen, everything is swollen and angry down there. And most of the signs and symptoms are similar to that of a cold. It is spread by a bacteria in respiratory droplets. Keep a patent airway and transport. Pertussis is contagious. Keep that in mind. You can catch this. You can bring this, home with you. So proper PPE. All right. That's all she wrote for that. But before we go away, you guys are going to have an assignment too, rather than just going away and killing time between now and 1 o'clock. So I talked about all the things that the pediatric assessment triangle shows you. and looking at this and actually doing it appropriately and actually being able to decipher what it is that you're looking at is really going to be number one. Because look at what it's actually telling you. So we're going to look at this first triangle right here. That dotted line means all three sides of that triangle are intact. The only time we can look at this and say we have a stable patient up to that very point is when all three sides of that triangle are intact. Their appearance looks good, their work of breathing looks noiseless, effortless, and painless, and we have positive perfusion signs. If we have just a little increased work in breathing, does it make sense that we have respiratory distress? But now if we add a problem with work of breathing and an appearance problem, well, shoot, there's our defining line for respiratory failure. Now we can see the increased work in their breathing, and we can see changes to their appearance, changes to the way that they respond to the environment. And we are still standing in the doorway. Now let's look at shock, because we can figure out shock with kids every bit as easy. If we have a problem with their circulation, just a problem with their circulation, we see signs of poor perfusion, some cyanosis, maybe some increased capillary refill time, maybe some just pale, cool diaphoretic. Well, kids are just supposed to be pink, warm, and dry like adults are, so we found a problem with the circulation to their skin. Kids have a very, very good ability when the time is right to clamp down their peripheral vasculature and flood all that blood back to the core where it needs to be. But their hands will be cold and this crazy dusky color. Well, we can look at that pretty straightforward and figure out how appearance and circulation are relative to a pediatric patient being in shock. A pediatric patient who is unresponsive or who has a poor appearance and isn't generally responding appropriately to their environment and has no other problem is very likely to have some sort of central nervous system compromise or some sort of metabolic issue. So check a blood sugar, make sure the respiratory rate is adequate, make sure that all the other sides of that triangle are actually holding up their end of the bargain. Because by the time we wind up with a problem of appearance, work of breathing, and circulation, the cardiac system is failing, the pulmonary system is failing, and we have a critically ill child looking right back at us. So there's your pediatric assessment 101. Anybody have any questions, comments, or concerns? All right. The assignment, no, is not going to be on Tavuti. You guys are going to go to EMS testing. Whoops. Let's try that again. You guys are going to go to EMS testing. Go to your EMS testing page, and you're going to click on adaptive testing in there. Yours looks a little different than mine because I have my instructor page up. Let's change that. There it is. So on the left-hand side, there should be a block for all of you that says adaptive testing. You're going to click on that. And you're going to click on new adaptive test. You can do a standard test, which is going to be somewhere between 150 and 200 questions. It's a lot. You want it to say National Registry. You could also do 30 minutes per module. We got plenty of time left. So you want National Registry as the curriculum. and pick a category, any category. We've done everything but operations. We've done airway breathing, we've done cardiology, we've done medical emergency, and we have finished trauma. So the rest of the lectures we have left are just tidying up this operations bit. But this is actually going to test you the exact way that the National Registry does. This is actually going to give you questions that as you get more questions right, the questions become harder. So this is going to give you a pretty good peek at how prepared are you. Did everybody follow that? And you need me to go through it again?
Can you repeat that, please?
Yep, I just had to make sure that I had all the right boxes checked. Hang on 1 second. So when you get to your student page, you're going to click this box right here, adaptive testing. You're going to create a new adaptive test. Whether you do a standard test that's not timed, that's going to give you a ton of questions, or a 30.
You just went out completely.
What?
I couldn't hear anything you said at all. It's like reconnecting every like 5 seconds. I can't hear you again.
I haven't said anything.
Okay.
So are you on your home page?
Yeah.
All right. Click on this adaptive testing box.
Okay.
Create a new test.
I'm sorry.
And then pick any of the modules that you want with National Registry grading curriculum. After that, click Start Test and you're off and running.
Okay, thank you.
No problem. And I'll see you guys all at 1 o'clock. I'll be watching for grades to pop up.
Okay.
Thank you.
Thank
You're
you.
welcome.